Welcome to Managing Complex Care Needs Wherever They Occur, a team approach. This webinar and telelearning series is brought to you by Can Do Multiple Sclerosis, the National Multiple Sclerosis Society, and the Multiple Sclerosis Society of Canada. My name is Brian Thompson, Programs Manager for Can Do MS, and I will be your moderator this evening. Can Do MS transforms lives. We deliver educational programs on exercise, nutrition, and symptom management to inspire and motivate long-lasting change for those with MS and their families to help them thrive. Please visit the Can Do MS website, mscando.org, to learn more about Can Do MS's online and nationwide in-person programs. Can Do MS is very excited to partner with the National MS Society and the MS Society of Canada to bring you 15 webinars in 2017. The mission of the MS Society is to help people affected by MS live their best lives as they stop MS in its tracks, restore what has been lost, and end MS forever. You can explore other societies' programs, services, resources, and connection opportunities at nationalmssociety.org. If you're having issues with GoToWebinar, please call their support line at 877-582-7011. Please also note that tonight's presentation will be recorded and available as an archive on our website, www.mscando.org, and you will receive a PDF copy of the slides. For those calling in, your phone lines have been muted. Tonight's presentation will offer a multidisciplinary look on managing complex care needs. The objectives tonight is to understand that complex care needs can occur at any stage of the disease process. Participants will be able to problem solve and prioritize complex needs with their healthcare team and explore helpful resources and strategies for challenging times. This is an interactive discussion, so we encourage you to be involved this evening, and you can do that in the bottom right-hand corner of your screen. You'll see a question/chat box. You can enter in a question at any time, and we'll save about 10 to 15 minutes at the end of the presentation to answer as many questions as possible. If we don't get to your question, we'll talk about other ways you can answer your questions and get more information at the end of the presentation. It's my honor at this time to introduce our three speakers this evening. Stephanie Buxoveden is an ICU nurse from Fredericksburg, Virginia, and upon being diagnosed with MS, she dedicated her career to helping people with MS take charge of their lives. She is an MS-certified nurse and works in an outpatient clinic as a neurology nurse practitioner, specializing in the care of people living with MS. Raz Kalb is a clinical psychologist specializing in MS care for over 30 years. She was involved with the National MS Society for 17 years and now serves as a Can Do MS Programs Consulting Coordinator for us, which we appreciate having Raz this evening, along with Mandy Werg, who is a physical therapist from Omaha, Nebraska. She works in an outpatient clinic specializing for the care of individuals with neurological conditions with a special emphasis in the treatment of individuals with MS. And she's also a Programs Consulting Coordinator for Can Do MS. So we're very excited to have Stephanie, Raz, and Mandy join us this evening, and it's my honor to turn things over to them.
Great. Thank you, Brian. This is Mandy Rohrig, just so you can recognize our voices. Again, I'm the physical therapist from Nebraska. Welcome, everyone. We'll go ahead and start by first talking about your MS team. So complex care needs occur throughout the disease and often involve gauging many members of the healthcare team. Many of them you see pictured in this illustration. Maybe your primary care physician, maybe rehabilitation doctors such as physiatrists, or even urologists can help you optimize your health during these complex times. And again, this illustration shows those common healthcare providers you may encounter. And despite perhaps feeling a bit outnumbered by all of these professionals, the person living with MS and the support partner are always at the center of the team and will help lead the decision-making of the team. And as mentioned, we are fortunate to have three of these professionals on the webinar today to help problem solve with you, all of us together as a team, the dynamic, complex challenges that people with MS and their support partners face. And we define complex care needs as one or more worsening symptoms that impact function and quality of life. It is often thought that complex care needs occur only with advanced disease. Well, that's not true. They can occur at any stage, such as after a difficult relapse or with disease progression. Complex care needs require coordination and careful collaboration with many of those healthcare providers you saw on the previous slide. And lastly, like many things in MS, many things in MS, complex care needs are highly individualized. So Roz, can you go ahead and start us on the vignette that we can problem solve together as a team with our participants?
Sure, thanks, Mandy. So I'm Roz Kolb, and I am a psychologist, and I want to introduce us all to Alice. She's a very dynamic and creative 7th grade teacher who has had a very severe relapse. Alice has a husband and 2 young daughters, which means that her life has been busy and active. And for the last 8 years, since her diagnosis at age 28, the injectable disease-modifying therapy that she's taking has really kept her disease pretty stable. Until now, where everything seems to be changing quite suddenly. Because of this very severe relapse, Alice has had to spend 10 days in hospital and was unable to return home right away because she's not able to walk very well. So her hospital stay was followed by 2 weeks of inpatient rehab. During that inpatient stay, a new MRI showed that she developed 3 new spinal cord lesions, which seemed to be responsible for the new bladder symptoms she's experiencing, her decreased libido, and all of the difficulties she's having with walking and balance. She also learned during that stay that her body mass index is pretty high and her vitamin D level is low. So she's decided that one of the things she has to do going forward is to focus a little bit on her weight. Her husband, Rob, is a very busy electrical engineer, has had to take over a lot of new responsibilities over the past few weeks. So he's taken on most of the parenting activities and the household chores in addition to his very busy job, and he's feeling overwhelmed and worried about how he can help Alice in the best possible way. Now, Alice, you can go to the next slide, please. As Alice has returned home, she is walking with a walker, but can only go very slowly and for very short distances because her new symptoms include very significant stiffness or spasticity in her left leg and some weakness in both of her legs. In addition, she's got very extreme fatigue, even more than her usual level, that interferes with all daily activities, including taking care of herself and others and the household. But most concerning is that since she's returned home, she's actually fallen 3 times. So Alice is now terrified that she'll never be able to return to that prior life that she had and the very busy teaching job that she loved so much. So she's very anxious at this time. She's feeling depressed. And she's also worried about the impact that all of these changes are going to have on her daughters. So clearly, as a result of this relapse, we're seeing that Alice has several complex care concerns. How she's going to get the disease process back under control again and manage her weight and any other health conditions. Her mood has been disrupted by all of these unpredictable changes that are pretty scary. Clearly the mobility challenges and the bladder challenges are interfering with her quality of life and ability to do things she wants to do. And changes in her feelings around her libido are making for intimacy issues. And both her kids and her husband have needs that also need to be addressed at this time. So what we'd like to do now, before we go ahead and talk about working with Alice to manage this, is ask you to help us figure out the priorities. So just take a minute, and if you were Alice in this situation, which complex care concern would you opt to address first with your healthcare team? Right, so there's some differences of opinion, but everything got some votes. But clearly the two that seem to be highest on people's minds are getting the disease under control and managing mobility. So let me just remind everybody that if we did this poll in a month or 6 months, Alice's priorities might have shifted, because priorities shift all the time. And each of you obviously had a very different reaction to all of this. So as Mandy said, these complex care issues are unique to each individual and each individual's priorities. So within our team, we made the decision, as you did, that we were going to work on some of the MS management issues that are feeling a little bit out of control. So now I'm going to turn it over to Stephanie, our nurse practitioner, to help us understand what are the next steps.
Thank you so much, Roz, and hi, everyone. And yes, we really did prioritize Alice's nursing care because we're really in what I call crisis mode, right? She's just gone through a major relapse, a hospitalization, and it's clear that we need to take swift action in order to get her disease under control so that we can succeed in getting her back from it. So first, she's already been hospitalized, and so we assume her relapse has been treated. But I did want to touch on relapse management because it's an important issue that a lot of us face. So having a relapse is not always a straightforward event, right? And a lot of people are confused about what a relapse is and how you can tell. And what we always tell people is a relapse officially is when you have any new or worsening symptoms that last for more than 2 days, and that can't be explained by anything else. So it's not that you're overheated or that you're sick or you're under a lot of stress, that it truly is the MS. And if you're suspicious, then the next step for you to do is to contact your provider, and they're going to be the ones that ultimately decide if this is a true relapse or not. They're going to order some tests, and then you'll have the option of whether to treat it with steroids or, like in Alice's case, if you need to be hospitalized, etc. And then, as Alice did, from the hospital, she's going to start focusing on rehab from there. Now, the big question in my mind is, should Alice consider switching disease-modifying treatment? And we really say that the criteria for switching medications is 2 new lesions or 1 new enhancing lesion, meaning that we're catching it when it's inflamed and active right at that moment, or if she has had several relapses. And certainly she has 3 new spinal cord lesions, which are extremely significant because spinal cord lesions are really what threaten her mobility. So I would say without a shadow of a doubt that we need to be talking about more effective disease-modifying therapy for Alice at this point. So now that we've decided about switching DMTs, we're going to go to the next slide and talk about treating some of these ongoing symptoms with talking about her bladder. And that's really the first thing I wanted to focus on because it's such a common MS symptom. I saw a few of you even prioritize that as the top issue, and I can definitely understand why. And there's a lot of things that we can do for bladder dysfunction. First, you can definitely talk to your healthcare provider about medications. We have a lot of different medications that can help control bladder dysfunction. There are medications that kind of help dry you up, and there are medications that will help the bladder muscle itself work a little bit better. And really we need to get down to the core of what's causing the issue. In MS, sometimes the problem is that the bladder muscle itself is very weak. Sometimes the problem is that the nerves don't sense the bladder filling, or that the nerves even oversense the bladder filling. And so it takes a medical professional to really figure out what the issue is so we can find the right medication and the right medical treatment for it. Now, things that you can do for your bladder function are really simple lifestyle changes. So a lot of people's first reaction to always feeling like they need to urinate and even being incontinent is to restrict the fluids that they're taking in. But that's really not the best thing to do, because if you stop hydrating, your urine becomes more acidic and it irritates the lining of the bladder, and it's actually going to make your symptoms worse, not better. So you do definitely want to remain well hydrated, but instead of sipping on fluids throughout the day, which is going to make you urinate more frequently, you can try just drinking water along with your meals 3 times a day. We also recommend something called timed voiding. And if you're like me, you've probably experienced the going to the bathroom and then 5 minutes later feeling like you have to go again. So that can be because the bladder's not pushing out every bit of urine that's sitting in there. So timed voiding is, or sorry, we're talking about double voiding. You're sitting down, you're urinating, 5 minutes later, you're going back to the bathroom, you're sitting down again. Whereas timed voiding, if you're like clockwork, every hour on the hour you need to pee, and you have that urgency, and if you don't get to the bathroom and make it in time and you have an accident, what you're going to do is maybe every 45 minutes before that 1 hour mark, you're going to sit down and you're going to take a bathroom break so that you never get to the point where your bladder is so full that you're having an emergent situation. And if chronic UTIs are an issue for you, there is an app that you can download on your phone called the UTI Tracker that will help you keep track of your symptoms and things that could be causing those infections and help you get that under control along with working with your healthcare team. So on the next slide, which Brian will get up for us, we're going to talk about fatigue. Fatigue is another really common, very disabling symptom of MS. We expect Alice to be dealing with fatigue right now because her body has just been through a lot. Having fatigue during a relapse and for at least 6 weeks after is considered normal, but doesn't mean that it does not impact her life. But hopefully we would see that starting to resolve as she gets better. So if her fatigue didn't resolve and she still was battling it even after she recovers, we would kind of look into what is contributing. So with Alice, her muscles are weak, she's having more trouble walking, and that's going to be sapping a lot of her energy, right? It's just going to be exhausting to do the everyday things. And we also have to consider her mood. She's having trouble coping. Understandably, she's very overwhelmed. And a lot of the times, fatigue is a very common symptom of depression. If some of the medications we have her on are either making her overly tired or causing insomnia, then she's also going to be fatigued, either directly because of the medication or because she's just not sleeping enough. And with her bladder issues, you have to think about, is that contributing to her fatigue? Because how well rested are you going to be if you have to get up to use the bathroom 5 times every night? So those are all things that you and your healthcare team will communicate about, and you can address those underlying issues if that is contributing. Now, if that still doesn't work, you also want to check the basics, because you can never forget that even though we have MS, there are still other health conditions that we can get just like everybody else, and there's a lot of different metabolic issues, heart disease, anemia, B12 deficiencies that can cause fatigue. So just checking basic blood work sometimes is informative. Now, what is Alice going to do after she addresses some of the underlying issues, right? So with muscle weakness, she's going to work with physical therapy. We're going to get her assistive devices, but it's a lot less effort to do the things, and Mandy's going to do a great job of covering that in just a little bit. But we're also going to have her kind of gradually get back into her daily activities. We don't want her doing too much too soon right after a relapse, right? That's just setting herself up for failure. So we're going to encourage her to kind of take it easy, take it slow, and get things going bit by bit. She's also going to have to watch her diet because she just had steroids to treat her relapse. And so those elevate blood sugar, and you want to make sure that you're not taking in foods that are too sweet or too salty, because that's going to make you retain fluid and make you feel a lot worse. And we're going to encourage her to exercise, because we do know that regular exercise is very effective for fatigue. And again, we're going to address her sleep hygiene, make sure she's getting enough sleep and not getting up too often in the night and not having insomnia. We're going to encourage her to rest throughout the day and to kind of a plan around her fatigue levels and to do the activities that she has to get out and do during the times of the days that she has the most energy. The next symptom that we're going to talk about on the following slide is her spasticity. And that's when your muscles are very tight and it can be incredibly painful. So we have medications that can treat it. We use muscle relaxers, and some people have to take those as many times as 3 times a day in order for them to work. And Mandy's also going to cover some stretching and some physical therapy interventions for that as well. And last but certainly not least, it's going to be extremely important for Alice to optimize her overall health. And she seems very motivated to do so. You know, it sounds like in the hospital, they let her know that she was overweight and she has made it her goal to lose weight. And that's so important because that's going to help you prevent other diseases, heart disease, diabetes, and preventable cancers, because, you know, MS is enough. We shouldn't have to deal with other things, and so whatever you can prevent, you need to. The other big factor is she has a vitamin D deficiency, and we know that vitamin D does protect our brains and our nervous system, so we definitely want her to set a goal of what her vitamin D level should be with her physician, and to make sure she's taking the supplements in the doses that her doctor prescribes. So next, I want to hand it over to Mandy to kind of go into some of those physical therapy interventions that I was alluding to.
Thanks, Stephanie. I think Alice is very fortunate to have you as her nurse practitioner, I do believe. So when Alice comes to see me, we would first identify those impairments and functional limitations that we would need to address in PT. So Alice's impairments are those MS symptoms that limit her function. So examples for her would be spasticity, or that tightness, that heaviness that she feels in her legs, the weakness that she might have in her legs, both of which are probably challenging her balance as well as her walking, compromising her safety and efficiency with walking not only in the home but likely eventually in the community and when she gets back to school. So a focus on improving that functional mobility both in the home, community, and at school will also lends itself to helping Alice find exercises that can help her with her weight management, which would also be kind of a functional limitation that we would want to address in PT. So maximizing her mobility will also help her to maximize her overall exercise. So how will PT help her address all of those impairments and functional limitations? We'll talk about some interventions in this next slide. So there are a number of PT strategies that I would use to help Alice. The first and arguably the most important is exercise. She needs to begin to learn how to move optimally in this body that feels so different and so unfamiliar to her. Exercises I would recommend include stretching exercises, and those stretching exercises would help her to manage her spasticity. So the National MS Society offers two excellent resources that are stretching manuals that can be done independently or with a partner. So I would probably encourage Alice to, once we've identified those muscles that need to be stretched and need a little more attention, I would probably encourage Alice to pursue this resource. Secondly, I would also start her on a strength training program that would address optimizing the strength of the muscles impacted by the relapse, but more importantly, address the overall function of walking, standing, transferring. The strength training prescription would likely be strategic, very strategic, as a matter of fact. I do not want her wasting her valuable energy on exercises that do not improve her overall mobility. Lastly, but not least, we would also include some balance exercises in her exercise prescription. And I do think this would be quite a critical piece to her program given her fall history. It's essential to kind of analyze the environment with Alice and with her family and identify those circumstances where past falls have occurred, and kind of look for themes or look for patterns in her falls. Say, for example, maybe Alice was catching her toe on a rug when she was in the kitchen, or maybe it's hard for her to get in and out of chairs, or maybe she's falling when she's turning her head or turning her body too quickly. All of that information can help me clue into what areas and how we can help her improve her balance with her exercise program. So a question that I suspect Alice would have is all of this loss of strength and all of this spasticity, all of these dramatic changes that she's experienced. How permanent will they be? You know, the loss of strength and increased spasticity is probably quite challenging. Sometimes a slight increase in spasticity can actually be helpful in this situation, as it can provide what I call some pseudo strength and pseudo stability. However, on the other hand, that stiffness can also make movement really, really hard. So that little strength and endurance that she does have is used up very quickly. So for Alice, it is challenging to say if any of these symptoms would improve, as it is with anything in MS. However, helping Alice to learn how to manage and respond to her spasticity and weakness will certainly be an absolute priority, and helping her look for those patterns and identify those patterns in those symptoms can also be helpful. And lastly, but certainly not least, I would help Alice find that invisible line. And this invisible line is that line that can move from day to day, month to month, hour to hour, minute to minute. That's that energy line. I would help her learn to understand how hard to exercise, how she needs to exercise to optimize the positive effects of exercise without crossing that invisible energy line, which can cause exercise hangover, unnecessary fatigue, all which are really not an effective sensation for her to feel, especially after a relapse. So on this next slide, I'm going to show you guys a few images of some exercises that I might use to help Alice. Now, this certainly isn't a comprehensive list of exercises, but just a few to get you thinking. In the upper left-hand corner is a repeated sit-to-stand exercise. I like this one because that helps with the strength and the balance that are necessary for transfers. We would progress this by allowing Alice to use her arms for assistance to not using her arms. The bridges right below that would help her strengthen her core, her glutes, her hamstrings, her quads, all of the muscles in the legs that help require strength for bed mobility, transfers, and certainly balance with sitting and standing. The marching exercise is the gal who looks quite happy in the corner, upper right-hand corner. I would recommend for Alice to do this given her fall risk, though, that she would have a chair in front for safety. I like corners, generally speaking, for balance exercises for all of you out there, simply because if you do lose your balance one way or the other, you're just going to bump into your corner. And if you have that chair in front of you, then you'll also be safe, as you'll have something to hold on to. And then the bottom right-hand picture is an example of a rocking or a weight-shifting exercise, so she can begin to understand what her limits of stability are and where is her new balance at. And in the next slide, we'll touch on a few additional interventions that we would do in PT with Alice. We talk first about assistive devices. We would explore all sorts of assistive devices for Alice. I would really encourage Alice not to feel like she needs to be married to one assistive device forever, indefinitely. We would certainly problem solve together, trying different aids in different situations. Maybe a two-wheeled walker is good in the house, but a four-wheeled walker is good in the community, so she has a place to sit. Just knowing that different devices can be helpful in different situations is really going to be a key learning message for Alice. Alice also, as far as family education, Alice also needs to feel empowered that she can do some activities on her own and she can communicate those activities to her family, as well as her family needs to feel confident that she can do some of those safely, and they need to feel confident and be able to communicate those needs as well to Alice. So this might involve, bringing in OT, or maybe a combination of PT and OT to help her. And lastly, a final thought about vocational rehabilitation. So vocational rehabilitation is a state-run service, and this might be a little bit later in Alice's rehabilitation process once we know her symptoms have stabilized. But I would perhaps encourage her to get in contact with vocational rehabilitation. Again, they are a service whose primary mission is to help people work and keep people working. They may help with funding workplace access modifications, and again, that might be a service that Alice might need to help her perform her best at work. So we were quite busy in PT, but certainly I think Alice would benefit from some psychology services as well. So Roz, how would you help Alice?
Thanks, Mandy. So I think we all as a healthcare team need to recognize that this kind of very severe relapse that brings some major life changes, major role changes, is pretty traumatic. And so the role of the mental health provider with Alice is to help her adapt to these changes that have happened. And that starts by supporting the healthy, normal grieving that a person goes through when there have been severe losses or changes that feel out of one's control. That healthy grieving has to occur so that people can then move on and begin to adapt to that new normal and begin to problem solve in an effective way. So we would talk together about these losses and changes and let her spend some time getting used to them. At the same time, we need to be helping Alice communicate with the important people in her life, obviously with her husband Rob, her daughters, and her employer and colleagues, along with the healthcare team. She needs to be able to communicate about her needs, how she's feeling, what her priorities are, what kinds of help she might need, and when she doesn't need help. And communication isn't easy. It frequently is made difficult by all of the strong feelings that everybody concerned is feeling when these kinds of changes and challenges are going on. So the mental health professional can really help with communication strategies. We can also help Alice and her husband think about how to plan for what is an unpredictable future. We don't know what's going to happen as a result of this relapse or how the disease is going to behave over time. And so planning for unpredictability is a very effective way for Alice and Rob to create kind of a safety net for themselves so they can be less anxious and focus on effective problem solving for everyday challenges. And also doing some goal setting for herself and with her family. One of the things that I care most about in a situation like this is helping Alice and Rob maintain their very effective, supportive partnership that they've always had. That kind of partnership can be thrown off the rails when this kind of crisis occurs. But we want to ensure that even though Alice is undergoing a lot of changes in her abilities and in some of the things she's able to do, that Alice and Rob both feel that they're in a partnership in which each of them is giving to the other, and each of them is receiving support and care from the other, so that the partnership continues to feel balanced and satisfying for both of them. That is the kind of satisfying relationship that is going to enable them to meet challenges going forward. And so with that, I'm now going to turn it over to Stephanie so she can introduce John, our second vignette.
Yes, thank you, Roz. We're going to shift gears and we're going to talk about a little bit of a different scenario. So we're going to introduce you to John. John used to be an attorney, but he was forced into retirement at the age of 62. He's had MS for the past 18 years and has now transitioned to having secondary progressive MS. And he is mobile with the aid of a power wheelchair, and he does still take his DMT that he was taking when he was still in the relapsing phase, which is common. One of his most concerning symptoms are his cognitive symptoms. He's having memory problems, particularly with the speed of information processing, and they are really what interfered with his work the most and drove his decision to retire. So now that he is no longer a practicing attorney, he's convinced that he's never going to find anything as purposeful or engaging as his law practice. His wife, Rachel, is a family physician, and she's concerned about his weight gain, the fact that he's smoking, and overall just that he's very inactive. And he used to really be an active person. He used to play sports with his sons, and so she would really like to see him find ways to be active again. So in addition to those things, on the next slide, we also learned that John has high blood pressure, and he was recently diagnosed with diabetes. He has concerns about pressure sores because he can't really feel as well as he used to, so he can't tell when he's in pain and when he needs to shift position. And since he's not very mobile and he's spending a lot of hours in his power wheelchair, he's having some skin breakdowns. He has bowel symptoms. He gets constipation along with urgency and occasional incontinence. And he's had nerve pain that is not responding to over-the-counter medication. John is the type of person who tries to brush his symptoms under the rug and ignore them, but since his wife Rachel is a physician, she's very concerned for his overall health. So he has a number of complex care concerns that we broke down for you here. So inactivity and weight gain, his bowel function, his pain, his mood and cognition, and his partnership and communication with his wife. We're going to do another polling question on John and ask you which complex care concern would you address with him first? Would you focus on his inactivity and weight gain, his bowel function, his pain, his mood and cognition, or his partnership and communication? And I'll give you guys a minute or so to answer that. And once again, we have people with differing opinions, which is great. So a lot of you said his inactivity and pain and mood were all a concern, but inactivity definitely won. And we couldn't agree more. We really want to see John up and moving, but we decided to address his mood and cognition because we saw some alarming things in him that we wanted Roz to kind of address first. So Roz, what do you think we could do for John?
Thanks, Stephanie. So as a mental health professional, I'm actually very concerned about John's mood when somebody has lost a role that has been so central in their lives, when they're expressing thoughts that this is a new reality and nothing is interesting anymore, nothing is satisfying anymore. We have to ask ourselves about John's depression. And we know that depression is extremely common in people with MS, much more so than in the general population or in most other chronic illnesses. And so we want to assess because we want John to feel better. We also want to determine whether he's at risk for self-harm given these major changes, because we know that suicidal attempts and suicidal acts are more than twice as common in the MS population as they are in the general population. So the first thing I want to do is assess John for depression and make sure that he's getting the treatment that he needs so that he can begin to tackle all of the problems that he's having. The other reason I want to assess for depression first is that we know that John has been experiencing cognitive changes and that they played a role in his leaving the workforce. But we know that depression can worsen cognitive symptoms. So we want to make sure that the depression is taken care of first, and then make sure that we give John a very thorough neuropsychological evaluation to determine what cognitive problems he's actually having, and then have him work with a therapist who can provide the strategies that he needs to deal with whatever cognitive changes he's experiencing. But again, we need to treat the depression first and make sure John is safe. Like Alice, we also need to help John with a normal grieving process. He really is having to redefine himself now that he can no longer be in his busy law practice. And he has to set new goals for himself so that he has a future that he looks forward to, that he engages in and enjoys. And most of all, we need to help him connect with his inner strengths, because he obviously has them, but he's kind of lost touch with what he brings to the table. So we need to help him find those. We can also be on his cheerleading team and helping him with all of the self-care and the healthy behaviors that Stephanie and Mandy are going to be recommending for him. Sometimes it's very hard when you're feeling this overwhelmed to fully engage with the healthcare team and take that central decision-making role that Mandy pointed out in the first slide. We need to help John be that leader for his team and also re-engage with his community. I think we also are going to need to work with John and Rachel. They come from very different points of view. Rachel is not only his very loving wife, but she's a physician and has very immediate, practical concerns for her husband and what she wants him to do to get better and take care of himself. And they may run into some difficulties talking about this, and the healthcare team, with the support of the mental health professional, can help this communication so it just doesn't turn into Rachel and John knocking heads. We want them to be problem solving together and also able to participate in shared activities that they enjoy, and Mandy's going to help them figure out what some of those shared activities could be now that his disability is increased, but they need to be able to talk through this well. So communication is a very important place where the mental health professional can help. Now, Mandy, I'm going to turn it over to you so that you can talk about physical therapy interventions for John.
Great, thank you, Roz. So there are a number of things that we would need to work on to help John and Rachel in this situation. So we'll first identify the primary impairments that he faces. So concerns with skin integrity, posture, and positioning in the wheelchair is of utmost importance to address because of the risk of contractures of the muscles, or potentially even worst case scenario infection from something like a wound or something that could happen. But they certainly all can be related, the posture and the pain and some of that core strength. So addressing the functional limitations of finding an appropriate position and creating an optimal posture in the wheelchair is very, very important. Similarly, if we can find some exercises that can encourage improved function and mobility in that wheelchair, that will not only help him with managing his skin integrity and his posture, but also help him with weight management and find more ways to interact in and engage with his family. So I look forward to working with John. So what types of interventions will we do during our sessions? First, we would investigate a variety of equipment options. So he needs assistance to maximize his safe independence with transfers while minimizing the caregiver reliance. John's this very powerful, intelligent, strong-willed attorney. We need to give him the tools to help him to feel that way again, because he can and he deserves to feel that way. So we would explore options such as maybe a sit-to-stand device, or maybe even a Hoyer lift frame that does require some assistance. If he is able to maneuver with pretty good stability, core stability while he's sitting unsupported, we also might work with transfer boards or sliding boards, which can help him transfer from surface to surface. But I would also add the most important piece about sliding boards or transfer devices is that we must respect skin integrity. Sometimes the shearing of the skin when lifting or scooting an individual can be compromised, and it can compromise already sensitive skin on the bottom. So that must be considered and certainly monitored throughout the process. Another piece of equipment that may prove valuable for John would be a standing frame. It would allow him the opportunity to stand for weight bearing through the legs, through the hips, through the spine, which might help counteract maybe any bone density changes that could be occurring because of his increased time in the wheelchair. Not to mention psychologically, that would feel really powerful to be able to stand and maneuver around. Additional skincare issues that I want to identify would involve probably collaborating with a wheelchair vendor, an occupational therapist, or an OT, and potentially a physiatrist as well, to determine if maybe a tilt feature or a power recline feature could be added to his wheelchair to help off some of the weight off of his bottom. A standing feature would be fabulous if we could get that added to his power chair, because again, access to those higher surfaces in his home can help with ADLs, and again, not to mention the psychological and confidence boosting potential that the opportunity to stand and have a conversation or interact with his friends, family, or in the community is really, really powerful. Also, coordinating scheduled position changes would be important for John to understand and start to learn and really be conscientious of, considering he has reduced sensation. But lastly, with any equipment recommendations or any changes that we might make to the power wheelchair, we would absolutely need to consult the team and the entire team, particularly PT, OT, and the physicians or nurse practitioners before buying any equipment or pursuing any equipment through insurance. And the reason being is there are often restrictions to how often you can get equipment, and we don't want you to end up with equipment that will not suit your needs for John's needs, for now and in the future. So please consult that team before buying. And here's just a few images of some of these devices that we're chatting about. So the one on the far left, the gal in the pink shirt, she's on an Easy Stand Evolve standing frame. So this is kind of a standing frame that may be helpful to allow him some weight bearing and some stretching and strengthening of the legs and of the trunk. The middle picture, the board that you see, is a sliding board. It's just a very basic sliding board that would allow John to scoot from surfaces to surfaces, from his wheelchair to other chairs. And then there's also one that he could use to help with toilet transfer. So you can see the sliding board that's placed on the toilet. And then in the upper corner is a Hoyer lift, which is a little more involved, but it's a maximal assist transfer device that's quite helpful as well. And I look at this photo again, and oh my goodness, if that's a PT or a nurse in a skirt, wow, we don't wear those anymore. So moving along anyways, we'll go to the next slide, please. Some exercises that we would do in physical therapy to help John. I would say the overarching goal for John's exercise program would be to find exercises that really empower him and help him to maximize his strength, and all while complementing his function. So core stabilization exercises, arm, leg exercises, and again standing would be really, really helpful for his situation. I would also add, and it's not indicated on the slide, that it might be helpful for some trials of maybe massage, gentle stretching, or TENS, which is TENS is a modality that we use in physical therapy that's an electrical stimulation device that often is helpful in pain management. So that may be an option we would try for John as well to help him manage his pain. And the last but not least would be, my role would be to help John and his wife explore options for adaptive sports and online exercise. I think helping expose both of them and hopefully excite both of them to the idea of doing sports again and maybe other physical activities together can help them realize that John can still enjoy sports, but he may just need to enjoy them in a slightly different way and with a few key tools. So listed on the slides are a few resources that we might encourage John to pursue or that we might educate him about, so we can look for similar resources in this area. Disabled Sports USA is throughout the country. It's an adaptive sports organization. MS Forward is an online interactive group exercise class that you can log on and participate in a exercise trainer-led exercise program, which would be good for John, that he could do from his home. And then the last site there is has archived online exercises, the nicpad.org. But again, regardless of ability or regardless of ability level, PTs and physical therapists can help you find ways to exercise. It's a key message. So again, a few pictures of some exercises that John might be able to participate in. The upper left-hand corner is an image of the triceps and kind of pectoralis muscles that would be involved with a lot of those types of transfers, as well as pressure-reducing strategies that we would educate John on using. The three pictures in the upper right-hand corner are the three different strategies you can use to do pressure reduction. The first one are dips, or where you just lift your hips up. The second one is leaning forward just to off-weight the bottom. And then the other one is side to side, or leaning laterally. And generally, we would recommend those movements, one of those movements, to be done for 15 seconds, held for 15 seconds, every 15 minutes, or 30 seconds for every 30 minutes. And then the lower left-hand corner is our founder, Jimmy Huga, sit skiing. He was the role model for just being determined to continue to find ways to enjoy sports despite changes in your disease. So he sit skied for his entire, and sit skied or skied for his entire disease, to my knowledge. And lastly is the gal in the lower right-hand corner. She's doing some trunk rotation exercises that would also be really helpful for stabilizing the core and would be helpful for John. So Stephanie, we've worked on really hard in physical therapy. I would ask now, how can nursing help this couple?
Right, and thank you so much, Mandy. I think all of that information was really informative and inspiring. So I hope all of you are ready to get out there and exercise. I'm going to shift gears and we're going to talk about bowel dysfunction. I feel like we spend a lot of time talking about bladder symptoms. Bowel symptoms don't always get the same attention. So I really want to take time tonight to kind of dive into that issue. And I really want to emphasize before we get too much in detail that everyone is a different normal, right? So some people have a bowel movement every day and some people only go once every few days. So don't try to stress out about feeling like you need to go every day. If that's not normal for you and if you're comfortable and you're not having discomfort, then that's fine. There's a lot of reasons that people with MS can have bowel dysfunction. And first of all, when I talk about bowel dysfunction, what I'm actually talking about is either constipation, diarrhea, urgency, meaning, just like bladder. You got to go and you got to go right now. And occasional incontinence can also happen. And sometimes people have a combination of all those things. And there are a lot of different factors in this. And sometimes it comes down to a lack of sensation. So you don't get that nerve signaling up to the brain saying, I need to have a bowel movement, and that can lead to urgency and incontinence. Dehydration is a big issue, and that can definitely cause constipation. A lot of medications that we use for pain, for spasticity, and a lot of those can cause constipation, and there are some disease-modifying therapies that can cause diarrhea and abdominal cramping. And immobility is a huge factor in bowel dysfunction. So if your body's not moving, your bowels probably will not either. And finally, MS lesions can directly also interfere with the nerve pathways from the GI tract to the spinal cord and the brain. So what do we do about it? First of all, we're going to start with the basics. He's going to increase his fluids and make sure he's well hydrated, and he's going to increase his fiber. He can either incorporate more green leafy veggies and whole grains into his diet, or he can get a little extra help by taking supplements. Like Mandy emphasized, we're going to get him exercising, we're going to get him moving, and we're going to get his bowels moving too. And if we do think that we're contributing to the problem with his medications, we can adjust medication regimens and talk about if we could even add some medications that would help out with his issues. So on the next slide, we're going to talk a little bit even more about what he could do at home to help. So just like with time voiding, sometimes people find it beneficial. 30 minutes after you eat, go to the bathroom, sit there for 20 to 30 minutes, and just try to go. And keep doing that until you're kind of on this regular time schedule. If you're still having trouble and you're constipated and you feel the urge to go, but nothing's happening, sometimes kind of narrowing the angle between your knees and your shoulders and getting your butt below your knees helps facilitate having a bowel movement. And there's a funny named product, but it actually really works, called the Squatty Potty, and you can look it up online. That does help with constipation. The alternative to buying a product specifically for that is just putting a footstool in front of the toilet, putting your feet up on it to get that angle. There are manual stimulation techniques. So some people find that gently massaging the abdomen in a clockwise direction can help. And with these, and sometimes people who, like John, has a physician wife, or if you have a home health nurse, they might help you with manual stimulation if you are impacted. So obviously, he's also going to want to avoid irritants. So caffeine, alcohol, spicy food, all of these things can be GI irritants, so he would want to avoid that, is to eliminate having a bowel movement as much as possible. And he really does want to discuss other medications with his doctor. And I know it's a really distressing symptom, right? Bowel incontinence can really isolate you. And I would say for John, a huge part of his problem is probably the constipation. The number one cause of incontinence is constipation, because you don't go, and then finally you have one bowel movement, and then it tends to be a blowout, a big one. So we really want to make sure that we're using medications to keep him regular, to facilitate bowel movement. And if he's having, those can be stool softeners. Sometimes we can use medications called anti-spasm medications if he's having pain. And if he's having diarrhea, you can use Imodium over the counter as needed. So shifting from bowel dysfunction, on the next slide, we're going to go into cognitive issues. Another really big distressing symptom of John's. In fact, it led to him cutting his career short. So John is really going to want to focus on his cognitive reserves. He's got to do something that challenges the mind every single day. And this is important for all of us. So get the brain moving, create new pathways so that your brain's more capable of overcoming the damage caused by MS. If that's still not working and you're concerned, you can consider having neuropsychiatric testing. So that would be something that you talk to your neurologist about doing, and usually there's a specialist in your area that can do comprehensive testing. And what I love about neuropsychiatric testing is that it really gets down to the core of the issue. Is it memory and attention? Is it fatigue? Is it, trouble focusing with abstract thoughts, reasoning? Are you a better visual learner than you are a verbal learner? It can really give you a whole, it's a lot of really great information that you can get out of it. And from there, you can consider cognitive rehabilitation and even maybe medications to help improve focus. Since he is having some memory issues, I would definitely have his wife or another friend or family member come with him to all of his appointments, because if you don't remember all the information, it can be really, really helpful to have an extra set of ears and eyes there. Staying organized is going to be key. So keep the house free of unnecessary clutter so it's not as difficult to find things. Use a calendar, set alarms on your phone, consistently keep things in the same place. One of my favorite tricks is if you're one of those people who's always misplacing their keys or something else, and you're always running around the house looking for it, what's the first spot you go to when you're looking for that missed item? Take that item, make that first place you look its new home. You also want to minimize your distractions. So turn off the TV, go to a room away from the kids and the pets, and really focus on the task at hand. And take your time. Don't rush yourself. Writing down information is important, but also verbally repeating it will help you remember too, especially if you are more of a verbal learner. So for instance, if you're shopping at the mall and you park your car and you're worried that you're going to forget where you parked your car, say, my car is in the third row, 10 spots down on the left. As you get out of the car and then go about your business, you're more likely to remember that now. And similar to the fatigue, you want to plan your cognitive tasks for times of the day that you're not as fatigued and you're more likely to be alert. And we're definitely going to take a hard look at his sleep schedule and make sure that he's resting optimally at night so that his mind is as sharp as possible during the day. Mandy did a great job of talking about some of the issues on the next slide, pain. So there's a lot of reasons that MS can cause pain. And we used to say MS doesn't cause pain, and we know that that's not true, right? So spastic muscles are painful. People with MS are more likely to have migraines. The pressure and skin breakdown that Mandy was talking about is painful. And finally, neurogenic pain. So there are treatments for all of those issues. We can help prevent headaches. We can help release spasticity. And we can give different medications that work for neurogenic pain. Mindfulness and wellness is a really important part of coping with chronic pain. And if none of those interventions succeed, I would consider seeing a pain management specialist who is a physician whose job is just to address pain. So again, on the next slide, Mandy already addressed his skin integrity. I would just add to what she said by saying, make sure he keeps his skin nice and dry. So if he's sweaty or if he does have an accident, we're going to make sure that we clean him up right away and get the skin dry, because moist skin is more likely to break down and then cause infection. And repositioning him regularly, and also getting his family and his wife involved. We're going to make sure we're checking that skin every single day and that we're looking for signs of skin breakdown. And just like with Alice, optimizing his overall health is key, especially because he did recently get diagnosed with high blood pressure and diabetes. So we're going to make sure that now he has those conditions. We're going to make sure that we're controlling them as best as we can, because all of those things can worsen MS symptoms. And we're also going to get him to quit smoking. We know smoking leads to a more rapid progression of MS, and it can actually make some disease-modifying therapies less effective. So if you smoke, you need to stop. That's an absolute must.
I'm going to remind all of you that you saw the team before, and you've heard tonight from a nurse, a physical therapist, and a psychologist. But as different complex issues arise, all of these other clinicians are available to work with you and your family to manage them. And now with that, I'm going to turn it over to Mandy for a final reminder.
Great. Thank you, Roz. So thank you all for joining us this evening to discuss complex care needs and complex care concerns. Hopefully our time together has helped all of you realize that complex needs are not impossible needs, and that complex needs are an opportunity for collaboration and problem solving with your team. Complex needs can be managed, and you can all do it. So thank you all for joining us.
Great. Thank you so much, Stephanie, Roz, and Mandy. And there's some more great additional resources here. And just so you know, everyone will get emailed a copy of the slides with these links, so you can just click right on them and find some great additional resources. We do have time for a couple questions, and we'll let you know about some opportunities to ask your questions if we don't get to them today. So the first question is a pretty loaded question that we could probably do a whole webinar on, but it's on planning. And the question is, should I plan ahead for changing disease states or wait until the needs arise? Do you have any specific suggestions on this mental planning, but also emotional planning on how to stay positive in light of potential worsening symptoms and fear of the future?
Well, since you mentioned emotional, this is Roz, and I'm going to just respond by saying that what I think planning does for individuals and families is to help them feel more prepared whatever happens in the disease course. My philosophy working with individuals and families is to help them plan for the worst, the things that they're worried about the most, but hope for the best. And by figuring out your financial planning, figuring out your living situation, talking to your healthcare provider about treatment strategies you might use if the disease worsens, you feel more secure, you feel more prepared, and you can spend less time worrying about what's going to happen and get on with living.
Absolutely. And I would just add, too, is that I always have, in addition to planning for the worst, I always have everybody prepare an emergency preparedness kit, right? So in case you have a relapse, how are you going to put dinner on the table for your family, right? That's my job in my family, is I get dinner together for everyone. So in my pantry, I keep food that I can make easily. I keep spaghetti and I keep pre-made sauce. We keep food in the freezer. But if I'm having a bad day or I'm going through a relapse, we have healthy, nutritious meals that are minimal preparation, no mess, no fuss. Also, I have a list of people that I would call on in times of crisis. So, you know, you have to say, if I can't drive, who would I call for a ride? If I can't go run errands, is there a person who I could delegate that task to? And having that plan gives you a sense of comfort. Also, speaking to your employer, talking to HR, there's a whole, like Brian said, we could do a whole nother webinar on employment issues, but if you need it, set up FMLA paperwork that protects you in case you do need to miss work for a stretch of time, and really understand your medical benefits. And I would keep your medical records and contact info for all of your providers at home, handy, ready to go in case you need it.
That's great. And Stephanie, you mentioned relapse, and there was another question about, so this person had an initial MS episode. Are there specific signs or triggers to know when a second episode or a relapse may be coming on, or is it completely random?
It can be random. Everybody's very different. Some people only have a relapse every few years. Some people have multiple a year. But really, to be a totally different relapse, it just has to be at least 30 days since the last relapse. And you're going to look for all the same stuff. If it's new or if it's a worsening of symptoms and it's been at least 30 days since your last relapse, then that's when you need to contact your healthcare provider for sure.
And again, on the topic of relapse, Mandy, we got a question. Are there exercises that people should specifically focus on after relapse, or are there other assessments that they should follow after relapse?
Sure. So everyone's presentation after a relapse is really varied. So I think the exercise prescription is also quite varied. So my best advice is in that situation, if you're going through a relapse or just having experienced a relapse, then get in touch with a physical therapist who can do a complete evaluation and then make the best recommendations for exercises that are going to set you up for success.
Excellent. Roz, this is a good question for you. This writer wants to know how to feel okay about experiencing symptoms when they're invisible to most everyone around you, and how to ask for help. Again, we could probably do 2 webinars on that.
That's true. We could certainly do 2. I think that there are a couple of things that are important to remember. Invisible symptoms are very common in MS. In fact, most symptoms are invisible to other people, which means they can't tell how you're feeling until you educate them. So it's important to be ready to put your teaching hat on. You can explain to people who are interested, or you can provide them with reading materials about MS so that they can learn to understand. But it's important to remember that those people, even if they love you very much and are very close to you, can't read your mind. So unless you describe what's going on, explain when you need assistance or when you're feeling better and don't need assistance, they're going to be stuck with guessing, and sometimes that makes others very uncomfortable, so they tend to maybe create some distance between themselves and you. So I think it's just important to explain what's going on, be ready to answer questions, and then let them know what you need.
I think that's great advice. Thank you. We have time for one more question, and Mandy, this is for you. We had a writer say, a lot of the exercises involving standing up. Any tips on how to modify these kind of exercises for people in wheelchairs?
Sure. So with folks in wheelchairs, and I'm not quite certain which exercise the writer was referring to. I'm guessing some of the ones with respect to Alice. So those could be modified for wheelchair users by, if you want to do some core strengthening, there might be more lateral weight shifting side to side from one cheek to the other, which was more similar to some of the exercises that John did. You can do seated Pilates exercises. So some of the same core strengthening exercises you could do laying down or standing up can also be completed in a seated position. So, I really truly believe that most, if not all, exercises can be modified for wheelchair users. Even some seated yoga can be quite effective for individuals as well.
Excellent. Thank you so much. And actually, we'll just got one good one in, and I'm going to direct it back to Roz because this is sort of her specialty. We had a question. When you are the caregiver and the family goes into crisis, what support is there to help the family?
It's a wonderful question. I'm so glad you asked it. I think all of us, whether it's at Can Do Multiple Sclerosis or the National MS Society or other MS advocacy organizations, we're all about helping everybody affected by MS. So we are as interested and eager to help support partners and family members as the person living with MS. So I think to make contact, with Can Do MS, or to call the National MS Society's 1-800-FIGHT-MS number and speak to an MS navigator. They are there to answer your questions, to help you figure out how to get support, to find the resources you need in the community to help you as a support partner or a family member. So don't hesitate. Your needs are just as important as the person living with MS, and we want to make sure that you're supported in the ways you need.
Well, again, thank you so much, Stephanie, Roz, and Mandy. I think that was a great example of how teamwork can really address these really complex problems, and I think we all wish that our healthcare teams were as collaborative and as comprehensive as what we saw tonight. So again, thank you so much, everyone, for joining us this evening. I do want to let you know about a few additional resources. First, with Can Do MS. We do have an e-newsletter that comes out every month. It's got some great resources. It includes library articles. In this coming up e-news, and on Thursday there'll be a great article written by Stephanie, Roz, and Mandy on some more complex comprehensive care issues. The library on our website has a wider range of resources and some great information. We also have a program called Ask the Can Do Team, and this is where you can submit a question, and we'll pass it along to our broad connection of MS care experts to try to get that answered. And we really want this to continue to be a conversation and to continue to look to Can Do MS as a resource in different areas of your lives. So definitely visit our website, www.mscando.org. And then, as Roz mentioned, the National MS Society has some wonderful resources on their website. And again, we'll email these slides to you so you can click right on these different links to take advantage of these resources. And the 1-800-FIGHT-MS number to talk to an MS navigator is a wonderful resource. We hope that you have enjoyed tonight's presentation, and will continue to tune into us on the second Tuesday of every month for our webinar and telelearning series. We like to cover a broad range of issues, and so our next topic is on health insurance, and there will be common health insurance problems in multiple sclerosis, solutions, resources, and strategies. And that will be on Tuesday, September 12th. And as always, it's completely free of charge, and you can register online at mscando.org. And lastly, if you have enjoyed tonight's presentation and would like to see more programs continued, there is an opportunity to be part of the Can Do MS family and to pay it forward. And you see a number on there if you're in a position to contribute to Can Do MS and to make sure that such programs can continue. We would love your support. All right. Thank you all so much for joining us this evening. Have a wonderful night.